Well, hello. Thank you for the introduction. I'm Shay Moskowitz. Thank you very much for the invitation again. I'm very happy to be here to present. Please ignore the bottom part of the title slide because, in fact, I just copied the title slide. Actually, this was not given at that meeting. This is just a cover slide for it. So, I'm going to give you some information that I'm sure everybody knows, but is always a worthwhile context, particularly when we think about demographics and need for solutions, when we think about the disease process itself and where it fits in societally. So this is kind of important when we think about numbers. Numbers represent a lot. The information here is from the Alzheimer's Association. They estimate that 6.7 million Americans over the age of 65 live with Alzheimer's disease type dementia just last year, of which an additional 17 to 22% of folks that are over the age of 65 have mild cognitive impairment. Now remember, mild cognitive impairment, I'll show this in a second, of course, this is a disease spectrum. So we have completely unimpacted, mild cognitive improvement, so you can do everything you need to do, you can take care of yourselves, you can live life, just your memory is not quite what it should be. And then you advance into phases where dementia is titled for disruption of normal behavior, normal activity. It interferes with your normal living. So MCI is usually the warning, the heralding portion of the disease where Alzheimer's disease is not yet fully impacted, but clearly is an issue. They estimate that about, we'll call it 1 in 5 folks over the age of 65 have already mild cognitive impairment. So we're impacting a huge percentage of our population. The lifetime risk is, if you're talking about a group of folks that are about 45 middle age, about 1 in 5 women will ultimately develop, 1 in 10 men will develop. Men die sooner, which is why the number is a little bit lower. They just don't live long enough to get that. Now, why do we talk about Florida? Well, because we live here. In Florida alone, just 5 years ago, there were an estimated 580,000 people with Alzheimer's disease in the state of Florida, which is, by the way, the number 2 state in the country. And they estimate that come next year, that number will go up to about 720,000. So there's a 24% increase in just 5 years. We're at the other end of that, so we'll see what the numbers actually bear out to be. But that is a huge number of people just in the state of Florida. It is the number 2 state in the country. So this data is based on clinical symptomatology. Now we all know that there are no lab tests for it. There's no imaging test that's widely available. So this is all based on information that's brought to the primary care doctor for which an evaluation or a diagnosis is then made. So who knows, it may even be higher. We care because the disease is progressive. It does not start at a certain point and stay there. We know that it progresses such that if you have mild cognitive impairment, so the early phases of Alzheimer's disease, 15% within 2 years will have progressed to dementia. Remember, dementia is defined clinically by your disruption or impairment of normal daily living. You take care of yourself. Forget severe, we're just talking basic stuff. You can't do that anymore. That defines dementia. And so mild cognitive impairment heralds, in fairly short order, progression of the disease, and 1 out of 3 will ultimately develop dementia in 5 years. And so the disease is progressive. If we don't get in front of it, we're going to have a hard time dealing with it. The value, pardon, is going to be in catching the disease early in order to potentially mitigate the course and the needs up and coming. So if we don't catch it early, by the time we do, we're often behind the 8 ball. Now, as we know from a systems perspective, dementia is an expensive component of our healthcare dollars. We only have a limited amount of money that we can spend on healthcare. We have a defined amount, but dementia and dementia diseases represent a huge chunk of money and resources that we spend in caring for these folks in every aspect of care. This includes emergency care. 1.3% of all ER visits are for people with dementia, and they're more likely to end up getting hospitalized, and they have longer hospital stays as well. In Florida, that's 1.5 emergency room visits per year per person. That's insane when you think about it. It means someone with dementia every 8 months is in the emergency room for something. Okay? In terms of hospitalizations, meaning inpatient, which are expensive resources, there's twice the number of hospitalizations. They have a longer length of stay in the hospital. They're more likely to die in the hospital of whatever disease they have, irrespective of the disease. If they come in with pneumonia, they're twice as likely to die than someone without dementia. What does one have to do with the other? Nothing, other than outcomes are much, much poorer. Then the readmission rate is 1 in 4, meaning if you have dementia and you're in the hospital, you have a 1 in 4 chance that even though you're going to go home, you're going to bounce right back. So the hospitalization utilization is extremely high. We know that they're almost 3 times as likely to have other medical diseases as well. Maybe that's because they don't manage their medications properly. Maybe it's because they don't know how to manage their medications properly. Maybe they don't have the cognitive ability to care for themselves in a way that they can control their diabetes well. So they're more likely to have other issues as well. And the increased use of other diseases, or the management of other diseases gets worse and worse and worse, meaning as you progress through dementia phases, your needs continue to escalate. So it's an expensive, taxing a component of our healthcare system. 50% of all nursing home residents have dementia. 1 in 3 live in a facility. 1 in 3 need home and health services. 28% of all adult day services are represented by folks with dementia. They have 5 times the number of skilled nursing facility stays. I mean, these are all statistics that shouldn't shock anybody. But at the same time, it's very clear dementia is a very expensive, taxing component of our healthcare system. So besides the fact that it's really, really debilitating, that it strips people of their independence, it strips people of their lives, it's stripping everybody as well, right? We all pay for it, even if we don't have it. So we all should be caring. Now the key in terms of population to identify are those folks that are in the middle. These are the folks that, so if you look at the continuum, we start with people who have no clinical symptoms, so preclinical. They have no clinical symptoms. For Alzheimer's disease, well, they don't need anything because they don't need anything. You advance into mild cognitive impairment, so you need help, but maybe not a ton, but you'd certainly need help. You advance into the early phases of dementia, where you certainly need more help, more supervision. And then at the very, very end, you have the farther advanced and ultimately bedbound and completely dependent side of the spectrum for Alzheimer's disease. Well, where are we going to make the most impact? On the left side of that slide. We're going to be able to make the most impact by treating folks, either treating them before they really have a problem. That's the lime green color. We got to get there yet. The yellow, which is they have symptoms, but they're not too far advanced, and even the light gray. These are the folks where we have the most capable place for impacting their clinical course, either arresting disease, reversing disease, supportive care. These are the folks that potentially can benefit the most. And in the state of Florida, there was other reasons why this was important since we care. If you just do some math, that basically counts for about 650,000 people that would benefit from more advanced, more aggressive, more involved care. So there's a lot of people, and that's just in the state of Florida. So there's a lot of people that we need to be dealing with. Well, how do we do this? Number one is with education. If we don't educate primary care doctors to identify early cognitive disease, complaints, open the door for conversations. If you never ask the question, how do you think your memory is going? If you never open the door, you're not going to get an answer. That's just harsh reality. People don't like to admit they're having cognitive issues, their memory's not good, that they're not really functioning as well as they used to. Some of it is independent, some of it is a strength of personality, a lot of it is cultural, a lot of it is situational. If you don't open your mouth and say I'm having a problem, you're going to have a very hard time getting the help that you need. So in order to do that, one of the efforts that we've made, at least within the confines of Broward Health with our primary care doctors, is provide screening tools. Ask the question, evaluate, be open to that conversation, have patient versions where patients can fill out forms to help answer the question, and tools with which doctors in their office can answer the question and evaluate, and tools with which they can connect to our memory center so that they can be more formally evaluated as is appropriate. So number one is bring this to people. Bring this to the primary care offices so they can identify people. Now, we look for technology to kind of advance this too, and that's largely because we've had really very little success in managing and altering the course of the disease with any other therapy that we've tried. It just doesn't work in terms of intervention. There's other conversations that I'm sure have been had regarding how you prevent, how you alter, how you slow down the disease. And unfortunately, it's hard because it's all lifestyle. Has anybody talked about that? Lifestyle modification? Is anybody going to talk about that? I might need to change my talk. All right, so why don't we do this? Let's talk about, well, let's talk about what I was asked to talk about, and then I'm going to talk about that because we're missing what matters, right? We're going to pivot a little bit. Okay, so ignore the slides. Okay, the reality is that see, if I had my laptop, I could run it up my laptop, I could immediately switch to a different talk. Sorry. Okay, so the reality is that this is a really bad problem, and there's no question about that. And the concept of brain health, which is something that has played a very personal mission for me, and plays forward, is simple. If we don't take care of ourselves, our brains are not going to follow. It's just that simple. I'm not going to tell you anything you don't already know, right? Everybody knows smoking is bad, right? Do I have to say it? No, sadly you do have to say it, because the reality is that as much as I say and you say no, I don't want to guess, I'm going to say nobody in this room, but we all know that cigarette smoking represents a multi-billion-dollar industry in just the United States alone. It's not, people aren't smoking because they don't know. People are doing it because it's an addictive habit, right? So just because it's called cognitive dissonance, right? You know the answer. You just, no. That doesn't apply to me, right? That's cognitive dissonance. You know the answer, but you emotionally disconnect from that in order to be able to live your life and do what it is that you want to do, misbehave. So we all know that that's true. The reality is that if we don't actually stop and think about all of the pieces of advice that everybody learned in high school, Health 101, we're never going to impact that, and that's not in the hands of any physician. There's nothing I can do to alter that. We know what they are, right? I joke about this with brain health. There's a couple of the commandments, right? Number one, watch what you put in your system, okay? You want to watch the fuel that you put in your system. If you eat bad food, your body's not going to perform. You want to eat well. What are we talking about? I'm not telling you anything you don't know, so you'll have to entertain me. We're talking about eating close to the ground, eating clean food, vegetables, complex grains, limiting red meat, limiting alcohol consumption. I'm not telling you anything you don't know. Everybody knows this, right? That doesn't mean don't have a glass of red wine, and it doesn't mean don't have a burger from time to time, but it means is that if that's your diet, of course you're not going to fuel it well. Change what you put into your system, and the reality is that the data continues to support that. Every study after every study after every study after every study, right? If you put better fuel in your system, you can slow down every single disease process. There is not one that is not improved by fueling your system better. Alzheimer's disease is on the agenda as well, right? So you fuel the system better, your brain performs better, lasts longer, you can stave away disease. In fact, there are some studies, and I don't know how you really quantify this convincingly so, there are studies in which converting your diet, even for someone with active dementia, somewhere on the spectrum, can reverse or alter the progression of the disease itself, which we say, oh, it's all about amyloid deposit, right? You can't stop it. We can't. We haven't been able to, but you can do that with diet. Okay, so that's number one. Number two, it's what you put out of your body matters. Well, basically, put out cigarettes, don't smoke, and number two, put out sweat. Exercise and activity. I mean, it's crazy that I even have to say this. I mean, it's funny, but it doesn't matter what you do. It's universal. Cancer, heart disease, lung disease. Go ahead, pick a disease. It's on there, name one, it doesn't matter. The answer is it's going to be improved by exercising, and you don't have to do a lot. 30 minutes a day is all the American Heart Association says you need to do, 3 times a week, that's it. Half an hour walk 3 times a week is enough to reduce your cardiac risk factor. We're not asking for a lot. Then, what you put into your brain, information, take classes, learn stuff, keep your brain active, puzzles, engage, use your brain. Use it, don't lose it, right? And then the last thing is social. It's amazing the lifestyles that improve health overall are ones that have social interaction. Not digital, but social. And pets count, by the way. They actually do count for that. So folks who have pets live longer than those that have no pets. Folks who have social circles live longer than those that have no social circles. It keeps your mind engaged. It keeps you open-minded. There's a lot of value to that too. So there's my little spiel about that. It's tier 2. If you do all of these things, half of the problems that we would have, if not more, would go away. Do you need medicine for that? I don't know. But I mean, there's a place for it, but that's got to come first. And I'm sorry, I will have that in the next time, okay? You need to take care of yourself. That is the key. All of this is very nice. Not anywhere near as important as how we take care of our bodies. And it doesn't matter where you are on this spectrum, the better you take care of it, the longer this spectrum will take to get to a point where you become dependent. So that really should be the takeaway for this talk. All right. However, what happens when that's not enough? And that does happen. Where does medicine fit in? And we've kind of fallen short because we don't have an answer. Not because we don't want to, we just don't have answers. And that's really been kind of very hard. Some technology has been used to try to help that out, and there's value in that. There is a treatment. It's experimental. I don't argue with that. Using low-frequency ultrasound to kind of open the blood-brain barrier, allow the brain to leach out all of the amyloid, which has been progressively depositing in the brain, allow that to leach out and hopefully alter the course of the disease. We all know that to a degree, and it's taken many, many years to prove that to be true, that amyloid deposits and tau proteins tangled up within the neurons are pro-inflammatory, they're pro-oxidative, they cause nerve cell death, and they ultimately are our mediator of the disease. So by removing the proteins, we potentially have the ability to alter the course of the disease. So experimental technology to try to do that too. To be determined how these clinical benefits will follow, as does with pharmaceutical stuff that come along. There's a lot to prove. The idea makes sense. Earlier detection or technologies to detect the disease earlier may allow for identifying people earlier in the spectrum, which means that if you figure out who the folks are that are at risk, you potentially have the ability to intervene sooner. Why wait till you're at the purple end of the spectrum, at which point it's, yeah, thank you. That's exactly right. It's just too late. You're right. It's too late. Now, maybe you can make it better, but for someone who's advanced and cannot take care of themselves, you're not going to, at this point in time, today, cannot, we don't know how, bring people back to fully independent. We can slow it down, but if you perhaps catch people sooner, then that allows you that potentially allows you to intervene on the process sooner as well. So technology can be used for doing that too. And it isn't yet entirely clear whether this is a single thing or in combination. Is that maybe it's possible that a lot of the newer medications need to be done in the context of blood-brain barrier and technology. So this may ultimately be a combination therapy. Find people earlier, clear their amyloid out, keep on top of them, alter their life, and then perhaps you can really alter the course of the disease itself. So to be determined where that plays out. At Broward, this is one of the things that we're trying. We meld everything together through our memory center, the evaluation and screening for folks that potentially are candidates for this trial as well. We also will make progress via partnerships with other associations. If we think we're going to do this alone, we are wrong. This is a multifaceted collective. And this is part of this too today, just so you should know this is part of it also. We have to partnership with industry, and that's fair. Industry needs to be involved for the development of that, and to that end, at least in the state of Florida, industry, particularly in SciTech, has worked with the state of Florida to pool together efforts from multiple institutions throughout the state, calling together an effort of academics for research and cohesive progress, shall we say, called the Brain State in Florida. And so the state of Florida itself, from a government perspective, Carrie, who I just saw 2 seconds ago, who you just listened to, help sew all of this together. It's through nonprofit organizations like the Alzheimer's Association, like this, for example, where we bring awareness, education, outreach. It allows us to collectively pull together all of these individual components through the Alzheimer's disease spectrum, and we can help facilitate that by bringing people together. So nonprofit associations are critical in that tie toward people. We have an interdisciplinary and collaborative approach across the state for education, for clinical practice, for government, for funding, to accelerate research. Finding tools to bring this together is not going to happen by ourselves. And so the state of Florida has been participant in that too. It really will require government involvement, as much as people don't like the government involving themselves in things. This is this is the spirit of many states. We don't want the government's involvement, but the reality is that this is one of the huge perks of having a government, in this case, our governor and the state of Florida, that's so vested in it. We need public policy reform. We need reimbursement changes. It's expensive, and if we don't cover these costs, people aren't going to get the care that they need. We can strengthen the response to programs through this government-related reimbursement modification. Clinicians need to be modified. It takes time. Clinicians who have to manage these folks need to be paid accordingly for their time, but the reimbursement for detection isn't there. The reimbursement for management is really kind of short as well, which makes it very, very difficult to convince the healthcare industry to support this when, you know, it's not reimbursed, which makes it really, really difficult. Compensation is not tied to the time that people spend, which means that a doctor can be paid X dollars for the amount of their time, but it may take 10 times as long to care for these folks. It's very, very hard to convince someone to do that. We need to expand codes for neuropsychologists, for screening tools, for social work, for case management as well. We could easily spend millions of dollars in direct work hours that we know that we're going to need, because if the disease continues to escalate in frequency, we're only going to need more support, right? So if we don't catch up with it, we're not ahead of it, we're going to be behind it as well. To that end, we talked about industry as well, but there's other aspect to industry, and that is the pharma piece, drugs. So far, nothing has really ever played out, okay? Nothing's been played out successfully in a convincing way until just last year. Prior to this drug was aducanumab, that's Aduhelm. Aduhelm was proven to reduce the amyloid burden in the head. It had its trouble getting through the FDA, which is another conversation, but it never really proved clinical benefit. All it did was prove that you cleared out the amyloid and made some assumptions about that. The next iteration of the drug is Leqembi or Leqembi. That drug, these are antibodies, by the way. They're antibodies that you get infused, and they help pull out the amyloid out of the brain. This phase 3 trial was published in the New England Journal of Medicine just last year, and that was the foundation for its FDA approval, in which they looked at the amyloid burden over time, and then they looked at clinical outcome as well. So on the right side, we talk about the amyloid burden, and that's really the amount of protein that's deposited. So the drug removes the amyloid. Fair enough. That needed to be proven as well. However, what was more important, and that's really what we care about, is disease progression. And that's the look on the left, is that the disease progression is slower in those that were treated with the Leqembi. That's really what we want to care about, is the clinical outcomes. And so based on this data, the FDA approved Leqembi for its use in this pivotal trial called Clarity, that showed that this drug does not just improve the imaging, but also improves the natural course of the disease. It does not reverse the disease, so we'll be clear about that too. They model that this was about a 2 to 3 year delay in the meantime to progression to the more severe stages. So you're basically buying somebody 2 to 3 years before they become into the purple zone, which is the advanced, moderate to severe dementia, where you're either bedbound or severely debilitated and in much, much greater need of help, at which point clearly we're at the later stages of the disease. So the use of the drug can slow that down by 2 to 3 years. That also modeled at about another half a year that it would take, that you can slow down admission to an institutionalized care setting. So we're keeping people out of skilled nursing facilities, and we're keeping people out of the more purple zone of the dementia spectrum by using this drug as well. The analysis would suggest that by delaying the onset by 5 years, it reduces total health and long-term care by 14% for every year you slow down the disease, which means that you can reduce cost and improve outcomes by 33% if you can slow the disease down by 5 years. This is a huge impact when you think about numbers and the cost, right? That purple end is really expensive. So if you can stay out of the purple zone, if we want to call it that, if you can stay out of the purple zone, you can really, really impact the cost on the burden on the system and on families as well. And so the logic yet to be carried out over time, since it's just a new delivery option, it really seems to be something that we can then deliver. Very, very quickly that came to public awareness. I mean, literally the same day that it was approved, it was in, that's the New York Times, the Wall Street Journal, and I think that's on NBC News. I mean, in the day that it came out, that it instantly became something that was on everybody's radar. Now, will we be able to do that? Realizing the value of the infusions, by the way, the treatment is, by the way, every 2 weeks. You have to be screened for it and be appropriate for it. It's not for everybody who's got the disease. So there are some very strict screening tools. But if you can be on this every 2 weeks, you get infused. It's still not by any means not disruptive. But the ability to realize the gains that one can get out of the infusion is going to be heavily contingent upon the processes for delivery. We have to not just have it, we have to be able to give it to people. That's not by any means insignificant. Actuating this infusion process has presented some hurdles that we have to understand and we have to address in order to bring this therapy forward. So just because we have it doesn't mean we can get it out of a vending machine and everybody gets it. It really is a process. And we've learned that both by trial and error. This is our experience at Broward Health. At North we have our memory center, one of the limited number of state-approved memory centers. We've developed that process and worked that out, but we've learned that there are problems that need to be overcome, challenges that we need to deal with, both with the site, personnel, selection, and cost. And not to go crazy with it, but the site requirements to be able to do this are intense. You need a memory center, you need pharmacy to be integrated, you need infusion centers. We need to have advanced imaging and radiologists that read these. We have to have a connection with hospitals, which we have. So it's not something you can do anywhere in anybody's office. When we think about people, we need to have doctors, we need neurologists, we need memory center clinical staff, pharmacists, we need radiologists, we need physicians and practitioners all working together to make that happen. That's a lot of people. The number of hours that it takes to give the drug, to screen through and give someone is about 20. That's what we found. It's getting better, faster over time. That's a lot of time to spend just to be able to give this to one person. So it's a lot of personnel hours. Someone's got to manage this? Everybody's got to be enrolled in a trial or a study or an aftermarket study to be able to capture the data. Someone's got to do this. It's not happening by itself. So there's a lot of personnel requirements that go into it. The patients are involved. That's not everybody. You need to be mild or early dementia. You have to have no risk for bleeds in the brain. You can't have lots of bleeds. You have to be able to show up. You need family support. Again, it's a very involved process. So there are a lot of hurdles that we've realized we need to work through to be able to make this happen in a fluid manner. We need the support, we need the environment, we need the clinicians, we need memory center personnel, we need everybody working together to make this happen. We need families that work with us to make that happen too. So there's a lot that goes into it, yet when you do that, it actually works. Here we go. I mean, to that end, at Broward, our memory center, has very quickly, as soon as the FDA approved it, we began the processes of working through protocols, imaging, pharmacy, get the drug, pricing, because it's not cheap, application process, screening tools. There's a lot of these things that we needed to very, very quickly build and make into a flow so our patients can get that. So just in the last, it's now 9 months since it was originally approved, we started being available for that only several months ago. And in that, just to give you an idea of what we've gotten. So we've already screened, this may be a month-old data, so I apologize. Antoinette can correct me if the numbers are now new, but we've looked to screen 27 patients at 4 months after that we rolled that out. In 27 patients that we've screened, half have failed. So it's really not for everybody, and it's not for not trying. So there's a large component of the population that's not even available to that. And of those that did not screen fail, meaning they could be eligible, 18% didn't want it. 1 in 6, they said, yeah, you're right, you can get it, but they changed their mind and decided they didn't want to get it anyway. So there's an educational piece. 1, that's the 4%, chose to go a clinical study route as well. And then so we're really only infusing 1 in 3, 30% of the people that we've screened. That's about 9 people, by the way. 8 people got infused. So getting people in, we can build the process into the credit of the Memory Center, to the credit of Antoinette and to everybody at Broward. We very, very quickly got on this because we know how important it is. And in doing so, we're doing everything we can to get every therapy available for everybody. That includes research, that includes drugs, that includes social work and social support. We're doing the best we can, but in the end, there's a lot left to do. Maybe we should be screening for people before they have a problem. Maybe we need a better screening tool. Maybe we should figure out who's going to get the disease, not who already has the disease. Is there something we can do to help alter that course so we don't end up in that place? And even if they do, how do we make it better? There's a lot for us to learn, but if we don't do this in a thoughtful, forward, progressive way, we're really never going to get there. So to some extent, this is where we start. This is how medicine starts. We bring this forward, we find a solution, we find a population that we can potentially help, and we get started, and then that expands forward. So to some extent, there's a lot that goes into this. Treating people with Alzheimer's disease from an interventional perspective, from a clarity perspective, is a very hard thing, and we've just begun the journey. So with that, I thank you, and this little slide at the end really highlights that Venn diagram of the integration of everybody. It has to be a collaborative effort. Pharma, they've got to come up with drugs. Technology, industry needs to find a way. We need nonprofit organizations that reach out to folks, such as the Alzheimer's Association. Here, for example, clinicians need to be involved, and our government needs to be involved as well. So by feathering everybody together, that's where we have the potential to make the impact that we need. Does not discount what I started the conversation with, which is take better care of yourselves, and so that maybe you never get here. But once you're here, the least that we can do is be integrated in how we deliver that care to everybody else. So with that, I thank you very much.